Hi, I'm Dr. Kathryn Pennington, and I'm a gynecologic oncologist at the University of Washington, and I'm excited to share with you things that are new in gynecologic cancer treatment. I have no disclosures. First, I'll talk about what's new in endometrial cancer, and I'll be focusing on immunotherapy. And then I'll talk about what's new in ovarian cancer with a focus on PARP inhibitors. So first, endometrial cancer. So first, I'd like to talk about immunotherapy in general. So there are actually many different types of immunotherapy. One specific type of immunotherapy is called immune checkpoint inhibitors. There are also other types of immunotherapy, such as vaccines and things like that, but immune checkpoint inhibitors is where we will focus. And so how does this work? In general, when someone has cancer, the tumor cell is always presenting little pieces of itself called neoantigens on its surface, and those are supposed to attract a T cell and then generate an immune response, with the idea that the immune system is supposed to attack tumor cells that aren't supposed to be there. However, unfortunately, tumor cells have figured out a way to evade the immune system often through a PD-L1 mechanism where they actually signal to the T cell not to get activated and activate the immune response. And so the way that immune checkpoint inhibitors work, and specifically anti-PD-1 checkpoint inhibitors, is that that's a medication that's an antibody to the PD-1, and it binds to it and it prevents that signaling from happening. So instead of the tumor cell turning off the immune system, now the immune system is able to be activated again and hopefully attack the tumor cells. So we have some predictors of who may respond to immune checkpoint inhibitors. We know that tumors that have specific DNA mismatch repair deficiency or microsatellite instability, which I'll be talking about more in a second, are more likely to respond. So the mismatch repair genes, MLH1, MSH2, MSH6, and PMS2 all fall in this category. And so people who have Lynch syndrome that have mutations in these genes would be predicted to potentially respond to immunotherapy. There are also tumors that can have mutations in these genes without having inherited it that also potentially could respond. Mutations in the gene called POLE, and also tumors that just generally have a high tumor mutational burden are all things that are predictors of responding to immunotherapy. And so what is mismatch repair deficiency, or what I'll refer to as DMMR? So the mismatch repair genes, we already discussed. If you have a mutation in one of these genes, this leads to defective DNA mismatch repair. So anytime our cells are replicating, sometimes there can be errors in how the DNA is getting replicated where there's a mismatch. And in the normal cell, we have a process to actually fix this using these mismatch repair genes, as you can see up on the top of that diagram. However, if someone had a mutation in a mismatch repair gene, then these proteins aren't able to fix the mismatch repair, and that can lead to defective DNA. The other term I want you to know about is microsatellite instability. So microsatellite instability is genetic hypermutability or a predisposition to mutation, very easy to make mutations that results from this impaired DNA mismatch repair. And so we know that immune checkpoint inhibitors may work particularly well in tumors with defective DNA mismatch repair. So in the example on the left here is a tumor cell without mismatch repair deficiency. And you can see how it's bringing in the T cell to activate the immune system. In the microsatellite instability tumor cell on the right, however, because there are so many more mutations in the cell, it presents more neoantigens, and it actually can bring in more T cells and have a stronger immune response. And so that's the idea behind why we think that they may be more effective. There's two ways to identify this. So there's MMR immunohistochemistry, which is staining the tumor for expression of these mismatch repair proteins in the tumor. On the left, you can see the stains are brown, and it shows that all these proteins are working to the best that we can tell and intact. And on the right, you can see that MLH1, there isn't, and PMS2, there really isn't much brown. Those aren't staining. So this is actually a mismatch repair deficient tumor. And then you also have PCR-based tests for microsatellite instability. And a tumor that has microsatellite instability high, or MSI-H, MSI-high, is on the right there. On the left is an example of a microsatellite stable tumor. And so one of the first indications for immune therapy that was very exciting for us was an approval for solid tumors that had MSI-high, or microsatellite instability. They did a study and found that in patients treated with pembrolizumab with a variety of different cancers, so colon cancer, endometrial cancer, biliary cancers, other cancers, that for tumors that had mismatch repair deficiency, or MSI-high, they actually had a significant chance of responding to the pembrolizumab. And you can see in here that endometrial cancer is included. And so we were excited about this, that this was a potential option for our patients. And so in May of 2017, pembrolizumab was approved for to be treated with any tumor that had MSI-high or deficient mismatch repair. There's also an FDA approval to treat solid tumors that have, in general, just a high tumor mutational burden. And so in the Keynote 158 study, which looked at treating pembrolizumab for a variety of solid tumors again, 13% of patients in that study had tumors with a high tumor mutational burden. And in those patients, they had a higher chance of responding to immunotherapy with a response rate of 29%. And so this also led to an FDA approval for treating solid tumors with tumor mutational burden high. So what about endometrial cancer specifically? So for deficient MMR, we know that Dostarlimab now is a very effective option for treating advanced or recurrent endometrial cancer. In these patients, there was an overall response rate of 42.3%, and the majority of these responses were very durable, lasting at least 6 months. And so just in April of this year, Dostarlimab was approved specifically for treatment of recurrent or advanced deficient mismatch repair endometrial cancer. We also know that for endometrial cancer tumors that have tumor mutational burden high, that is also a predictor of response to Dostarlimab. And so even tumors that were mismatch repair proficient, meaning they didn't have that MMR deficiency or the MSI-high status that was previously what was needed to get immunotherapy, that tumor mutational burden high also predicted a good response to immunotherapy with a response rate of 45%. And most of the tumors that had MSI-high also had tumor mutational burden high, or vice versa. But on the bottom here, you can see there was a proportion of patients that their tumors were mismatch repair proficient, so wouldn't have otherwise been eligible for immunotherapy. But 7% of those patients still had tumor mutational burden high status in their tumors. And so there are some patients, even with mismatch repair proficiency, that still may respond to immunotherapy, but not as many as we would like. And so what about immunotherapy for mismatch repair proficient tumors, microsatellite tumors? So we have data in several different immunotherapy, immune checkpoint inhibitor drugs that I have listed here, where we can break down response rates by if the tumor is mismatch repair deficient or if it's proficient. And we already, as I've discussed and shown you, know that there are high responses to immunotherapy in the MMR deficient group, but we've been more disappointed in the mismatch repair proficient group, with responses ranging anywhere from 3% to only 13%. And so we needed another therapy that could be more effective. And we're very excited about this discovery, that when you use a combination of immune checkpoint inhibitor therapy with pembrolizumab and add Lenvatinib, which is an oral drug, it's a multi-kinase inhibitor, that specific combination appears to be much more effective in mismatch repair proficient tumors with a response rate of up to 40%. And so this led to accelerated approval in September of 2019 for advanced endometrial cancer. Lastly, this led us to wonder Well, how effective is this compared to chemotherapy? Is it possible that we could use immunotherapy instead of chemotherapy? And so in the Keynote 775 study, this was a study of patients who had advanced or recurrent endometrial cancer that had already had prior chemotherapy. They were randomized either to receive a new chemotherapy regimen, either with doxorubicin or paclitaxel, which are common chemotherapy agents used in endometrial cancer, or they were randomized to receive Lenvatinib with Pembrolizumab. And in this study, we found that the combination of Pembrolizumab and Lenvatinib was significantly an improvement over standard chemotherapy, with a significant improvement in progression-free survival or decreased risk of recurrence, and improved overall response rate of 30% compared to 15%. Even more exciting is that we found that it helped our patients to live longer. There was improved survival in the group of patients who received Lenvatinib and Pembrolizumab compared to those who received chemotherapy. And so this led to an FDA approval that was just recently granted on July 21st, 2021, and is a new standard of care for patients with endometrial cancer that have recurred, that we can consider using immunotherapy instead of chemotherapy for treating. So next, let's talk about updates in ovarian cancer. So as an overview, patients get their upfront treatment with a combination of surgery and chemotherapy, and then the vast majority of patients get into remission. And then the question is, should we consider maintenance therapy? So what is maintenance therapy? Maintenance therapy is treatment given after the completion of chemotherapy to decrease the chance that the cancer will come back or to delay the cancer from coming back. And it's given to continue or maintain the good results of a prior treatment. So in the frontline setting without maintenance therapy, the traditional chemotherapy sequence would be a patient gets their chemotherapy and get into remission, and then they'd be monitored off treatment. If the cancer came back, then they would go on to receive second-line chemotherapy. In the maintenance therapy sequence, patients get their initial chemotherapy and get into remission, and then they go on maintenance therapy. If their cancer came back, then they would go on second-line chemotherapy. But the idea is that if that happened, the maintenance therapy hopefully significantly delayed the time to recurrence, and they were able to enjoy more time off of chemotherapy. In the recurrent setting, it's similar. Patients can get a remission and after primary treatment and be monitored or get maintenance therapy. And then if they have a recurrence with second-line chemotherapy, if they have a good response to that treatment, then they can go on maintenance therapy again. And so these are the FDA approvals for maintenance therapy in ovarian cancer right now. And the ones in red are the new ones that I'm going to be highlighting for you. So before the updates I'm going to give you, we had maintenance treatment for recurrence. So if someone had a complete or partial response to chemotherapy in the platinum sensitive setting, they could get a PARP inhibitor with either olaparib, niraparib, or rucaparib, or they could get bevacizumab maintenance therapy. Or in the upfront setting, anyone can get bevacizumab that's been previously approved, but we'll talk about these newer approvals with PARP inhibitors. So PARP inhibitors have been transformational for many patients in the upfront setting, especially BRCA1 and BRCA2. And I'll be talking about 3 trials that have led to changes in practice. The first one is the SOLO-1 trial. So in this trial, after patients had their remission or had a good response to their primary chemotherapy, they went on maintenance olaparib for 2 years. And this was patients only with BRCA1 and 2 mutations. So mutation carriers, or where their tumor had a mutation of BRCA1 or 2. And the results in this study were dramatic, a significantly improved progression-free survival, 70% lower risk of cancer progression or death. And if the cancer did recur, it took more than 40 months longer for it to come back if a patient was on olaparib compared to if they had received placebo. And so this was incredibly exciting, and this led to the FDA approval for olaparib for frontline maintenance therapy for tumors with BRCA1 and 2 in December of 2018. So a lot of people ask, what about mutations in non-BRCA genes? So the data is more limited, but the biology, understanding what we know about these mutations and how they work, would support that mutations in genes that have similar functions to BRCA genes also may be responding to PARP inhibitors. We think this is especially true for RAD51C and RAD51D, which are other genes that can cause ovarian cancer and function in a similar way, and maybe also PALB2 and BRCA1 and potentially others. The other thing I want you to know about when we're talking about these trials is what is HRD, or what is HRD testing. So HRD stands for Homologous Recombination Deficiency. HRD is a measure of defective DNA repair. Mutations in BRCA1 and BRCA2 and other HR genes lead to HRD, or this deficiency. We know that the best predictor of responding to a PARP inhibitor is having a BRCA mutation, but just having HRD through these other mechanisms is also somewhat predictive of having a response. And so there's a lot of interest in, can we test for this to see who else besides BRCA1 and 2 carriers can benefit from PARP inhibitors? These tests look for evidence that there was HRD at some point in time, but that can sometimes change. And so it doesn't necessarily indicate current status. And what I mean by that is it's an imperfect test. And so we'll talk about that more. And so in the next trial I want to talk to you about was the PRIMA trial. So this was all comers. This was individuals with BRCA mutations, but also individuals who did not have BRCA mutations. And so after primary treatment, they went on maintenance niraparib therapy, that's a different PARP, for 3 years. And in this trial, when they looked at everyone, they saw that it also had an improvement in progression-free survival, although the difference was not as huge compared to as what we had seen in the first trial I showed you. It was about a 5.6-month difference. But this led to the approval of niraparib for frontline maintenance for anyone with ovarian cancer, not just BRCA1 and 2 carriers. When they divided up into groups, so they looked at these categories of HRD, they saw that people who had BRCA mutations had a significant difference, that niraparib really helped in those situations, but also people who didn't have BRCA mutations but had the HRD based on that test I was telling you about also significantly benefited, and that benefit was pretty similar among those two groups. There was a much more modest benefit in patients who didn't have HRD or where their tumors were HR proficient. There was still a benefit with the niraparib, but it was much smaller, meaning that by being on niraparib for 3 years for maintenance therapy, up to 3 years, it did delay the cancer from coming back, but it only delayed it by 2.7 months compared to if the patients hadn't received treatment. So that's a much more modest benefit. And then the last trial I'll tell you about is the PAULA-1 trial. So this was patients with and without BRCA1 and 2 mutations, but that received bevacizumab with their initial chemo. Remember, that's another drug that is approved for maintenance in the upfront setting. And then in the trial, they randomized people to either just staying on bevacizumab maintenance for their maintenance therapy or adding olaparib to that. So they would get olaparib and bevacizumab after their primary treatment. And again, in this study, it showed that there was a benefit. And so the combination of olaparib and bev for frontline maintenance was approved in May of 2020. Again, when you look at the groups, we see that the difference was most significant, or a biggest benefit, in BRCA1 and 2 mutations. There was still a significant benefit in HRD positive tumors that didn't have BRCA1 and 2 mutations specifically, but had HRD through other mechanisms. But then tumors that were HRD negative or HR homologous recombination proficient, that it looked like adding olaparib didn't make any difference. So in that subgroup, there was no benefit to adding PARP inhibitor. And so conclusions, based on these studies, we already knew that for individuals with BRCA mutations, that PARP inhibitors are excellent. We also know that for individuals with HRD, but that the tumors are BRCA negative, PARP inhibitor is not perfect, but it's still very good and very beneficial. But then we have an unmet clinical need for HR proficient tumors or tumors that don't have HRD, that there is still some benefit with niraparib, but not nearly as much, where people may want to weigh the risks and the benefits. And so the next update I want to talk to you about is a really big clinical question that has come up. So now, we used to give PARP inhibitors for maintenance in the recurrent setting. That's how we first learned how to use them. But now that we're giving them at the brand new upfront setting after initial treatment with chemotherapy and getting into remission, if we're using PARP inhibitors upfront, then what do we do if then someone has a recurrence later, but they already received a PARP upfront? Can we reuse PARP inhibitors? Will they still get the same benefit if we give them again, or is that not useful? That's been a really big question. And I'm excited to be able to tell you that we now are starting to have some answers to this question. And so the OREO trial, this just got presented in abstract form. It was studying olaparib retreatment in recurrent platinum-sensitive ovarian cancer. So patients have to have had a recurrence and have already been treated with a PARP inhibitor previously. And then when they go on to get their second-line chemotherapy, they have to have responded well. And then they're randomized to getting either olaparib maintenance therapy again or a placebo. And so this was just presented, and we found that, in fact, there are definitely some patients who can benefit from getting a PARP again. It did improve progression-free survival. So this was in patients with a BRCA mutation specifically. And as an example, at 12 months, 19% of patients who were on the olaparib had not had recurrence at that time, whereas in the placebo group, everyone had had a recurrence. So this significantly is making a difference for some patients. We saw the same thing in the non-BRCA cohort, so patients that did not have a mutation, that it still appeared to be beneficial with giving another PARP. All right. They tried to look at specifically for the non-BRCA cohort also this question of HRD testing. And it appeared that both in HRD positive tumors and HRD negative tumors that there appeared to be a potential benefit, but that's in exploratory analyses. All right. So there are a lot of questions about what causes PARP inhibitor resistance, because if we understand that, then we can potentially target it to try to overcome that. So there are different categories of what can cause this. So one is you can have restoration of homologous recombination DNA repair activity, either through a direct mutation or through indirect mechanisms with other kind of signaling pathways. There are also other pathways having to do with cell cycle control and replication stress that can contribute to PARP inhibitor resistance. And there are other mechanisms, for instance, there can be a pump that makes the cells hard to uptake the PARP inhibitor where it pumps them out, things like that, a lot of different mechanisms. And so a couple of these mechanisms people have looked at to say, are there ways we can overcome this? So adding an anti-angiogenesis agent. So angiogenesis is new blood vessel growth. So adding an anti-angiogenic agent to a PARP is one mechanism I'm going to talk about, and some preliminary data. Adding an ATR inhibitor to a PARP inhibitor is another. That's a really exciting combination right now. And lastly, WEE-1 inhibitors are also really exciting. And so I'll talk about each of these with recent data that we have. All right, so first is the EVOLVE trial. And so in this trial, patients progressed on PARP, and then they went on cediranib, which is an anti-angiogenesis agent combined with olaparib, and they evaluated whether or not patients responded to PARP inhibitor or not. And if you look at the chart on the right at the top, the partial responses, it shows that there were some partial responses, both in platinum-sensitive tumors and platinum-resistant tumors, or patients that had progressed directly on the PARP inhibitor. as well as some disease stabilization. So the PARP after PARP didn't work perfectly in every patient, but there were some patients that benefited. More importantly and exciting about this study, or as important, I should say, is that patients who went on this study got biopsies right before they went on the cediranib and olaparib. And then the investigators also got archival tissue from their prior therapy from before they went on a PARP inhibitor, where they could look at changes to start understanding what is causing resistance to PARP inhibitors. And we learned a lot of important information with that, that we're still learning. Next is the EFFORT trial. So this is a study of combining a PARP with a WEE-1 inhibitor. And so patients who had progressed on prior PARP were randomized either to getting the WEE-1 inhibitor alone, adavosertib, or combined with olaparib. And in this study, many patients had received a lot of prior chemotherapies, on average 4 to 5 prior chemotherapies. So they had a lot of prior treatments. It was a mix of BRCA positive and BRCA negative tumors. And we saw that these are active agents. So in BRCA mutations, there was a response rate of 20% with the WEE-1 inhibitor alone, and similar in the WEE-1 inhibitor with olaparib. The clinical benefit rate included people that not only had a response where their tumor shrunk either completely or partially, but also patients who had disease stabilization. So their tumor stayed the same, it didn't get worse. And the clinical benefit rate in the WEE-1 inhibitor group was 67%, and it went up to 81% with the addition of olaparib. We saw similar findings in tumors without BRCA mutations. There was a response rate of 31% with the WEE-1 inhibitor alone, and 39% with the WEE-1 and PARP combination, and a clinical benefit rate of 69% versus 94%. So that is a really exciting combination that we're looking forward to getting more data on and hopefully being able to offer to our patients. And then lastly is the CAPRI trial. So this was combining a PARP inhibitor with an ATR inhibitor. And so this is patients who had benefited from a prior PARP, but then ultimately had a recurrence despite their prior PARP. And they received olaparib with the ATR inhibitor ceralasertib. And in this study, again, we saw it had considerable activity in patients with an overall response rate of 46%. So that is very exciting. In summary, significant progress is being made, and it will continue to be made. Please also remember that by definition, 10-year survival rates are 10 years out of date. And that the time we make an effective discovery and start treating patients, it takes a full 10 years to actually update the improved statistics. Thank you to all of the patients and their families and loved ones who have participated in research studies that allow us to improve outcomes for individuals with gynecologic cancer. I will look forward to answering your questions, and thank you.